Hi, my name is Tessa Olson and today is April 28th, 2019. The following video is my case connection submission for Unit 4 of Medical Biochemistry through the University of New England. Of the available options, I've chosen to discuss Case 1, a case in which a normal-appearing newborn starts exhibiting some alarming symptoms soon after birth, as well as Case 3, where a 47-year-old male presents with severe right foot pain and is later diagnosed with gout. So let's get started. In Case 1, a normal-appearing baby is born, but within 24 hours, her condition begins to deteriorate. Soon after birth, she begins to exhibit hypothermia, lethargy, and apnea. The first question in this exercise encourages us to think about which test we would order and why. It asks us to decide which test can distinguish between a urea cycle disorder, or UCD, and a beta oxidation disorder. So we're given the following choices to choose from: blood glucose test, urinary acids test, serum fatty acids test, and a plasma glutamine test. So let's rule out a couple of these choices quickly here. First, blood glucose tests and serum fatty acid tests can be indicators for deficiencies in many metabolic pathways. For example, a newborn carnitine deficiency in beta oxidation will exhibit both hypoglycemia and lipid accumulation in test results. Yet, even if this deficiency is the cause of low glucose levels or a buildup of fatty acids, these tests aren't specific enough to both pinpoint only beta oxidation deficiencies as this patient's primary pathology. Nor can these tests rule out a deficiency in the urea cycle, since there are a variety of other conditions that would cause similar test results that aren't necessarily part of either of the two pathways we're evaluating. For example, diabetes or gestational diabetes. So in other words, the elements being tested aren't specific enough to affecting one cycle or the other. More testing would need to be done to determine which cycle is lacking. So we can eliminate testing blood glucose and serum fatty acids as primary indicators. Urinary acid tests can give useful information for both UCDs and beta oxidation disorders, but they can also be a little bit misleading. A deficiency in beta oxidation cycle could impact the production of ATP, which could in turn affect the urea cycle and nitrogen disposal. So once again, this test alone wouldn't be specific enough to help us rule out or pinpoint a deficiency in either cycle. Given the sudden onset and the severity of symptoms in this child, we should be highly suspicious of a urea cycle disorder. These symptoms are among classic symptoms associated with this enzyme deficiency at any point along the cycle. However, patients with beta oxidation deficiencies can also exhibit some similar symptoms. So let's think about what we know about the urea cycle and break this down further. We know that the urea cycle consists of 5 biochemical steps that are necessary to convert ammonia to urea, and that both ammonia and glutamine are precursors for urea production. If any of the cycle enzymes reduces flux through the cycle, elevated levels of ammonia in the blood will develop. So glutamine is a non-essential amino acid that aids in the detoxification and transport of ammonia. If the urea cycle is not functioning properly, levels of glutamine in the plasma will also rise and can serve as an indicator of UCD deficiency. Glutamine behaves a little differently in normal beta oxidation cycles than it does in the urea cycle. The levels of glutamine will appear closer to normal in normal beta oxidation. However, they can still be elevated in cases of deficiency. It's not very common. For example, there are cases of fatty acid disorders that can affect activation of glutamine dehydrogenase, which would affect plasma glutamine levels also. But for the most part, glutamine testing can pinpoint a urinary cycle disorder with relative accuracy and is the best test to order. This makes testing for increased plasma glutamines the best answer. In their research on tandem mass spectrometry, Garg and Dasuki also agreed, stating that quantitative plasma amino acids are the single most useful laboratory test in distinguishing the different metabolic defects in urea cycle metabolism from transient hyperammonemia of the newborn, which is less common and usually occurs in a sick newborn. So back to the case. For good reason, the physician suspects a metabolic disorder and ordered an array of labs. I won't go over them specifically, but the blood ammonia level at time 0 was very elevated and then rapidly rose to 600. Normal range is about 17 to 80, so very, very high. Urine uric acid levels were markedly elevated as well, about 473. Normal is about 0 to 3, so extremely high there. And plasma citrulline levels were a little bit lower than normal at about 10. Normal is 12 to 55. So from these labs, the case connections exercise asks us to list one urea cycle enzyme that is most likely deficient and one enzyme that is least likely to be impaired. So in this case, the urine orotate levels, reminder, orotate comes from an alternative metabolic pathway for pyrimidine synthesis in the cytosol. So these urine orotate levels are very high, suggesting that carbamoyl phosphate accumulation is occurring. So we can guess then that carbamoyl phosphate synthase is actively producing carbamoyl phosphate, and it's accumulating because ornithine transcarbamylase is not using the carbamoyl phosphate pool to produce citrulline. So as a result, the urea cycle would not continue properly and ammonia would continue to build up, which accounts for the very high ammonia levels we are seeing in this patient, as well as the lowered citrulline levels. An enzyme we know would not be affecting this particular patient would be arganosuccinate synthase and or arganosuccinate lyase. A deficiency in either of these two enzymes would mean that urine orotate would be very low or non-existent, suggesting a non-accumulation of carbamoyl phosphate, as well as very high levels of citrulline. So essentially, a deficiency in either one of these enzymes will demonstrate symptoms and lab results that are the exact opposite of those that our patient is exhibiting. This is why we can effectively rule out that a deficiency of either of these two enzymes is at play. So for the next case, case 3, we have a 47-year-old man who presents to his care provider with severe pain in his right foot, specifically his right toe, great toe. He states that the pain is so significant that he can't stand or bear weight, but he's had no traumatic injury that he can remember, and states that the pain started the previous evening and has gradually worsened to this point where he is now seeking medical attention. Based on preliminary findings, he is diagnosed with gout. So let's take a look at this patient's lab results. He was administered both blood and urine tests, and they came back with pretty remarkable results. His blood test demonstrated that he has elevated plasma urate levels, which we would expect, compared to the baseline range of less than 7. This patient's urate levels were at about 10.5. And his urine test is especially remarkable given that they are much lower, about 215, compared to the baseline normal range of 413 plus or minus 78. So I would have expected them to be a little bit higher. So in this case, we're posed the question, what is the best explanation for presentation of gout in this individual? And please explain why other choices are not consistent with this data. Or what additional information would you need to decide the root cause? So the choices are 1, overproduction of purines, 2, decreased salvage of purines, and 3, decreased urinary excretion of uric acid. Intuitively, all of these answers seem like they could be valid and could contribute to a gout diagnosis, so this is a little tricky. In week 15, of course, we learned about the presentation of gout and how it could really result from any of these 3 factors. So based on the information provided thus far, I'm kind of inclined to select answer 3 because of the low uric output this patient is exhibiting, uric acid output that this patient is exhibiting. But answer 1 also has merit, as overproduction of purines is very typical of modern day patients, especially given the foods rich in sugar alternatives and exogenous purines. So it really could be either one, choice 1 or 3. The other reason that I would maybe pick choice 1 is the sudden onset of this patient's symptoms lead me to believe that he's overproducing purines rather than suffering from a more chronic renal condition that would affect uric output. And the fact that we don't have a very comprehensive history for this patient makes me want to investigate a little further. So if I had to eliminate an answer right away, I would likely eliminate choice 2, decreased salvage of purines. While decreased salvage of purines can cause hyperuricemia similar to what we're seeing with this patient, it's also typically associated with enzyme deficiency in the purine salvage pathway. So typically enzyme deficiencies like these are recognized much earlier on in life, as these symptoms can be quite startling and can include severe neurological defects, gout, and self-mutilating behaviors. These are definitely symptoms that wouldn't have gone unnoticed by the patient or his family. And given that this man is just now presenting at age 47, and we aren't really given any significant history about his mental status, it's unlikely that this is his particular cause of gout. As for the other 2 choices, they could be relevant causes of gout, and more information is definitely necessary to make a final judgment call. Thankfully, the case goes on to provide us with a little bit more history that is helpful in making this choice. This patient goes on to state that he recently switched from drinking 4 to 5 liters of artificially sweetened diet soda per day to drinking 4 to 5 liters of sugary containing soda, namely high fructose corn syrup and corn syrup. So right away, this tells me he's suffering from gout as a result of overproduction of purines, choice 1. This patient's gout is likely being exacerbated by the extreme increase in fructose consumption. As we learned in Unit 2, fructose is phosphorylated to fructose 1-phosphate by the enzyme fructokinase, and then can enter the glycolytic process. So overloading the liver with fructose, high levels of fructose can cause sequestration of phosphate, which leads to lessened ATP production. Less ATP production leads to an overproduction of de novo purines and an increase in uric acid formation, which would contribute to the hyperuricemia this patient is experiencing. For good measure, I would definitely want to test this patient's kidney function also in order to rule out the very low uric acid output that this patient's urine Forgive me. For good measure, I would definitely want to test this patient's kidney function also in order to rule out the very low uric acid output in this patient's urine, and make sure that that wouldn't be due to renal malfunction. It's very rare to have such a low uric output, and even though the patient didn't present with renal symptoms, it is possible that a combination of both purine and overproduction and kidney disorders, a combination of both, could be affecting him. In addition, I would advise this patient to reconsider their beverage choices in the hopes that symptoms might lessen and his condition might normalize. So that is what I came up with for my Unit 4 case connections. Thanks for listening. Have a good day.